So we are is everyone familiar with like what ECMO even is? Does anyone not know what it is? Okay, awesome. So I'm actually gonna have Tony kind of start us off, and then we'll go from there.
So, hey everyone, there's some faces here I recognise. I've been a nurse for almost 30 years, most of it started off in the SICU at the U, did a little bit of ED stuff, I didn't like that much, and then I went to Air Med for 12 years. I think I started just after Cookie. But I was in the same hiring group as Stel, and then I was Embley's preceptor, which was funny. Funny stories about that. But so I was a flight nurse for I think 12 years total, and about 3.5 years ago, I decided to stop dealing with all the crap, and now I sedate people so that they can enjoy their colonoscopies every day. So I get to work with a lot of assholes. But anyway, my story is the night after Thanksgiving in 2013, I was working a shift with Larson, and we were down in Nephi, and it was cold, miserable night. Weather was kind of a factor, and we got launched to Saratoga Springs for an auto-ped, and it was a 16-year-old kid that got tagged by escalator at an intersection right on I think it's Redwood Road, and I can't remember the cross street, but he got tagged doing 65, something like that, and thrown a long way. And so we got there, and they had him kind of all packaged, but his GCS was 3, and blood coming out his ears and nose and eyes, and everything was broken, his pelvis, his legs, his arms, his chest. And when I picked up his head, I loosened off the collar to intubate him and moved the back of his head up, so I could get a good look at his airway. And the whole back of his head was moving, and his eyes were staying still, and his face was all broken up. But we intubated him, did good, and he was rock stable, right? And so we were on scene, loaded him into 407. Jeff gets into the head of the bed, and we hand him all the stuff and start bagging the kid. I come around, Beth Fisher, I don't know if you guys remember, everyone run into her. She was the pilot. She started spinning up the aircraft, and just as I hopped in and closed the door, the kid all of a sudden, the first thing he did for the whole transport, he's got all his blood starts coming out. So I start frantically drawing up some drugs to put him back down again, stop him coughing while we were getting suction out. And you guys can imagine the cluster that was going on. All the fire crews were off towards the 10 o'clock position, and so while we went to do that, realised that someone had folded up all the IV tubing and put it underneath the buckles down by his knees, and we can't reach it in the 407, right? So we had no way of giving him the drugs. So because Larson is lazy and he's not very good, I went down the tunnel, being the skinniest and most flexible, and I went down the tunnel by the patient's feet, right? And as you can imagine, for me, there's some stuff in the way. And so there I am, all crunched up, gripped the IV and redid the buckles, and as I sat back up, I realised I couldn't breathe. And so the day before, on Thanksgiving Day, I'd ridden my bike down over Suncrest from Sugar House, where I live, to my in-laws' place in Cedar Hills. So that was like 65 miles or something over Suncrest, so I was feeling fine. And so anyway, I sat back up and I couldn't breathe. And so I handed Jeff the drugs, and he's still bagging the patient. He's looking at me like, I get out of the aircraft, I'm sweating, panicking. I take off my coat, I took off my helmet, and he said some cuss words to me, accused me of not being entirely masculine. And, and I was like, I can't breathe. So I'm trying to grab some oxygen tubing and plug it in. And I don't think it was a conscious decision, but I realized had to do something, so I got back in the aircraft, put my helmet on and said, let's go. And so this is all taking a minute or 2 minutes, and I'm feeling panicked, my heart's pounding, and wasn't much longer after that I passed out. But the last thing I remember was as we kind of come up and out of Saratoga Springs and we're booking it towards the point of the mountain, I remember, because Jeff's like, what are you doing? And I remember looking at the university, because you can see it from a long way away, and I remember looking at it and thinking, whoa, that is a long way away, as I'm kind of going out, slumped against the door. And so a couple of days later I woke up in the unit that I worked in for 14 years, and nurses I'd trained and managed and hired and all that kind of stuff, and one really good friend, and I woke up because they wanted to know if my head was okay, because I had 9 minutes of anoxia, and EMED people kind of tucked in the corner watching over me. And I remember being kind of on my side and looking at the row of IV pumps, and there was 13. And usually in the ICU you count how many pumps you got, you know how bad you're doing, right? Like 13 was about the most I'd ever seen. And I looked up at the monitor, and my arterial blood pressure was only 5 higher than my pulmonary artery pressures, which means that my heart was not doing very well. And I was like, oh shit, I'm in trouble. And then I looked down and I had these 2 big hoses, one with dark red and one with bright red blood coming out of my leg. And the nurses would freak out anytime I'd bend my knee, because you can't bend your groin. So when I had gone into the ED unexpectedly, no one knew I was coming. They didn't know what was going on, so they scanned my head. They took me and squirted my arteries in the cath lab. All of that was clean. From everything I've heard from the people who come up to this day, I still get people in the ED coming up and saying, like Karie told me last week, that she was there. And the amount of people that were there the night that I nearly died is crazy. So after 7 days, 3 days I think I was on ECMO, maybe 4, something like that. I bagged myself to the OR when they took it out, which the anaesthesia guy got in trouble for. And but it wasn't hard. You just like lie there. And the anaesthesia guy was cool, because I've known him for years. He's like, man, if he stops, we know he's passed out. And, so got that pulled out. Then I got extubated later that afternoon, and yeah, so many things from that day, from those times. But anyway, after 7 days, I went home, and I still remember being home. The first day it was snowing like crazy, and got woken up. There was one of our flight nurses was shoveling my driveway, which was crazy. And then I walked the kids to school, which is 300 or 400 yards, but I cut through another school on the way to do it. And as I'm walking through this little school, and I got my 2 dogs, 2 little kids, and this car pulled, a little rusty red Subaru Outback, right, and it pulls up next to me, and the window winds down, and it's Troy Matson, was the doc that resuscitated me in the ED, and he'd been to see me in the ICU, and he looked at me, and he just, like, his eyes, he just welled up, and I'm like, I was the same. I'm like, I can't do this, Troy. I can't do this right now. Let's just, you go your way and I'll go mine. So yeah, after a couple of months, I went back to work and worked for another, I think, 7 years. My pH, when I come in with PEA, so I had nothing, right, no pulse, nothing. And it was 9 minutes of Larson's support and comfort next to me. I think he hit me with his chest with his elbow a couple of times, and pulled me off the door, which sometimes pops open. So my pH was 6.5 and my lactate was 24. The best save I ever got in the unit or flying or Eva was 6.8, so it was pretty close to the edge. And then, so yeah, that's my story.
You forgot to tell them about how the OB nurses jumped on your chest and started doing CPR.
Oh yeah. So they don't do CPR on full-size people very often. So yeah, they had a hard time getting me out of the helicopter because of dead weight in the bottom of the where you put your feet in the helicopter. And does anyone else know Kent Harrison from DPS? He's one of the pilots, big, rangy, skinny old guy. He just single-handedly just scooped me up because the girls couldn't move me, and because I was like 180 pounds. And he just dumped me on the gurney, and then the cutest Air Med OB girl got on top of me and did compressions while she straddled me. But I'll never let her forget that. Apparently I was conscious when she did that, but that's what I told her. But yeah, so yeah, that's my story. So, when we debrief back calls that are crazy, right, that have an impact on us, we're all, most of the time, 99% of the time, we're talking about stuff that went wrong, right? I've been there, I've done stuff I shouldn't have, and been there, I got away with the skin of my teeth, and Cookie and I have done stuff together. You always have stuff that goes wrong, but my case was, I was incredibly fortunate that every single person that was with me, that worked on me, that made decisions regarding my care, every single thing contributed to me still being able to parent my kids, right? So no one made the wrong choice. Larson could have stopped and dropped me off at IMC, and that I would have been dead. They didn't have ECMO program, right? He flew the extra, 1.5, 2 minutes over the top of IHC and took me to the U. He had to keep bagging that kid. Larson and I are as close can be, and even in with one of his good friends going down right next to him and him being powerless to help, he made the right choice. And then all of the people made good choices.
Well, we're
Awesome.
glad they did it. That's awesome.
Any questions?
Do you guys have any questions for Tony?
The kid died, by the way.
I was going to ask that.
Yeah, he was always going to die.
What, you probably said, what ended up throwing you into arrest?
So undiagnosed cardiomyopathy. That looking back afterwards, I was able to, some very, very subtle symptoms, like when I swam a lot and worked out a lot, and some very subtle symptoms that in hindsight made me think about, maybe, my heart was obviously at risk. But I think what happened is when I pushed my big fat belly down onto my groin and was struggling, my heart was pounding, my adrenaline was pounding because of the kid. And then when I sat back up, I think I vapor locked. The docs can't explain it, but I think I just overwhelmed an already fragile tachycardic system, right? And because I just I couldn't move air in or out. I was in florid fulminant pulmonary edema when I got into the ED and needed huge amounts of PEEP to push all the fluid out.
Well,
Okay.
Oh, thanks for sharing that.
thank you.
Cheers.
Okay, so throughout this presentation, I just want to reiterate that this is for educational purposes only. I'm not proposing that you guys change your protocols or anything like that. I just want you guys to be aware of ECMO and for the potential use of it in your guys' communities. I'll just wait for this to load. Oh, there we are. We're in business. Okay, so there are two types of ECMO. There's VV and VA. VV is lung support only. These are for your severe acute reversible respiratory failure and can be used as a bridge for lung transplants. This type of ECMO is really, really popular during COVID. For obvious reasons. And then you have your VA. This is used in patients who have severe cardiac failure, such as cardiac arrest patients, lung and heart support. They use the VA often after a heart transplant or some pretty hefty cardiac surgeries. So this is kind of a diagram of VA ECMO. It's very, very simple. So I'll let Dr. Tona kind of talk about this, but I just really quick want to go over two things. You're going to hear me use some like terminology, and I just want you to be aware of what that is. So the garden hoses that Tony was talking about that go through your groin, you have a venous and then arterial, and that's when you put those hoses through, that's called cannulation. So we will often cannulate patients even before we even decide if we're going to put them on circuit. The circuit is this pump and then the oxygenator here, and that's it. So it's a very, very simple process. Dr. Tona?
Yeah, that's a lot of it. All ECMO is a thing called a pump and a thing called an oxygenator, and the pump just moves blood from point A to point B. And the oxygenator adds oxygen. It also removes CO2. It's the same thing that they use in the OR for cardiopulmonary bypass. It's just a lot fewer sensors and bells and whistles, but ultimately that's literally the same company, same circuit, same parts. It's just, for ECMO, it's just those two things in tubing. If you pull the blood out of the veins and you return it to the veins, then it doesn't give you any inherent blood pressure support, because it's not in the arteries where your blood pressure is. So that's VV. It just oxygenates, goes from vein to vein, and it adds oxygen, removes CO2. If you pull it out of the veins, you stick it back in the arteries, it does the same thing. It adds oxygen, removes CO2, but it also gives you blood pressure because it goes back to the arteries and it pressurizes that system. And that's VA ECMO, which is what we're talking about for ECPR. When people, if your heart stops, you need the blood pressure. That's the simple way to think about it. You may or may not need the lung support, but you get it anyway.
So this is a picture of our first ED ECMO that was done at the University of Utah. Dr. Tona actually headed up this program. He helped start it. Dr. Tona is a CV intensivist, so he helps care for the patients that go on ECMO in our CVICU, and then he also is an emergency room doctor as well. So he was a great person to help start this. And I show this picture for a couple different reasons. One, because it's really cool. You can see someone's in cardiac arrest here and they have their Lucas on. The Lucas goes the entire time that you're cannulating these patients. But a lot of resources go into these patients. So we have what we call an ECMO eval. It gets activated by our charge nurses, and it just brings down so many resources: lab, EKG, CT surgeons, CT intensivists, cardiology, ED doctors. You got your nurses from the CVICU, you got your ED nurses that are participating, you got your EMTs. Like, just by the time that everyone's like in the room for this one person, it's actually pretty incredible to see. It's like more than 50 people in that room to save one life. So that it takes time to get all these people down into one place. So why ECMO? It's a last chance for these patients. They have a higher chance of survival if put on ECMO than continued CPR. CPR is terrible. Your chance of survival is less than 10%. And our survival rates, if put on ECMO, if they meet our criteria, is about 30%. So we never put patients on ECMO to be like, yeah, this is going to be a donor. Our reason for putting a patient on ECMO is to save a life. But potentially, this could be an option for some people, and some families do decide to do that. So one of my jobs as EMS liaison, I wanted to better understand your guys' world. So I've done quite a few ride-alongs, and I want you to know that I can appreciate that moving a cardiac arrest patient is a crap show, right? It's a circus. It's a lot of work, and I did not realize that, because obviously all the patients come to me and I just do my thing. But now my eyes have been open, and you guys work really, really hard to get these patients here. I wanted to show you an actual video of a cannulation. if you've never seen it before, it's super cool. And I'm gonna have Dr. Tona kind of talk about what they're doing here.
So this is, these are people out of France. They do a lot of ECMO out in the field. And essentially what you can see is you got a drape on top of the patient to keep the field clean. And it's a sterile procedure. It doesn't always stay perfectly sterile, but we do our darndest to try and keep it sterile, even in situations where there's an arrest. So they do a modified version of this. Not everybody does it this way, but that's the groin. It's probably their left groin. And what they've done is they made a cut, and they're trying to bluntly with their fingers identify the femoral vessels. And you use your fingers because in theory you can't rip a vessel with your finger unless you really try. And so now they're kind of opening it up, and they're trying to see where the vessels are. And then they're sticking a needle in through the skin, and they're going to kind of come out into the hole that they've made. And right there they've gone into the vein, or what is probably the vein. It's very dark blood. I mean, it doesn't have any oxygen in it, or not much. And now once they leave the needle in, they stick this wire in. And the point of the wire is to hold the spot in the vessel. Because then they can basically use that wire as a lead to guide things blindly into the vessel. And so now they've put that big blue thing as a dilator, and it's going to basically stretch out all the tissues. They made a cut to cut the skin, because the skin doesn't stretch, and then that's the cannula going in there. You can see it's pretty big. Wire comes out, and then they're going to pull out the white thing, which is like a plug in the cannula, and all of a sudden blood will start pouring out. And then they'll clamp it so it doesn't keep pouring out. And then they go to the other side. Now they're going to go in the artery, and they're going to do the same thing. The blood might be just as dark as you can see, because even when you're getting bagged and you're in cardiac arrest, it's really hard to tell what's a vein and what's an artery, even looking at the blood. Both the veins and the arteries can become pulsatile with compression, so it's really difficult to know which one's which. Same thing, wire in, and then they feed in this catheter. The one in the artery is almost as big, a little smaller. Goes all the way in, pull the wire out, pull the white thing out, clamp it, and then they're going to hook up these two tubes. And the tubes go to the thing that we talked about before, which is it first goes to the pump, and you're going to see the blood when they turn the pump on. It's going to go in the top one there to the pump. And then it's going to go through the pump, it's going to go into the oxygenator, it's going to get a lot of oxygen and come back bright red.
Does anyone have any questions on that process? I know it's kind of the nitty gritty. So Europe has been doing this on the streets for quite some time. So they have two doctors. Like if you look up ECMO in Paris, you can actually see them. There's like a famous picture of a patient being cannulated in the Louvre. So they and some places in the United States, so specifically New Mexico and Minnesota, there are surgeons out in the street placing this. And it's really, really cool. So we primarily do this in the emergency department. And we are the only ones in Utah that does ED ECMO. So we cannulate our patients in our emergency room. So I'm just showing you a few graphs for a couple different reasons. So this is post-cardiotomy and like survival and neurological rates. And the reason why I'm showing you these graphs is essentially just to show you that like we do these a lot. So last year we cannulated 87 patients. And in order to be efficient in this process and good at it, you have to do it quite a bit. Now there's a different environment because these ones are being done in the OR. This is a different environment, right, in the emergency department when someone's had a cardiac arrest. We recently expanded our criteria, and we wanted to capture patients like Tony in PEA. So it used to be that we were only taking in patients in VFib and VTAC. We have expanded that now. And as I'm talking about this process, this is a very fluid process, meaning that there are over 12 surgeons that help make the decision to cannulate these patients and put them on ECMO. And kind of everyone has a different threshold. I think that we see that a lot in medicine, right? Even as medics and EMTs, like, there are some people that are more conservative and some that are more liberal. But these are the basic guidelines that we have, and I'll go through some examples. So our inclusion criteria is any adult under 70 years old. Again, that's fluid. So an example I like to give is there was a 75-year-old woman who was in our echo lab. She was overdosed on lidocaine, and she went into cardiac arrest. She was activated as a rapid response. We went and picked her up, brought her in our bay, and as soon as we got to our bay, she went into cardiac arrest. So I was working that day. We coded her for 2.5 hours. She got put on ECMO, and she walked out of the hospital 7 days later, and she was 75. So it has to be a witness cardiac arrest. So what does witness mean? It means that not you just saw them go into cardiac arrest, right? It could be anyone saw them or heard them have a cardiac arrest. So if you have a loved one that goes upstairs or is in the next room and you hear a big thud, you go in and they're a cardiac arrest, that is a witnessed arrest. With that, this bottom one, the no flow state under 10 minutes, if it was witnessed, someone needs to have started CPR within 10 minutes. Obviously, if they're calling 911, that 911 operator is going to help prompt that person to do CPR. And then again, any rhythm if witnessed. So, Tony, PEA, right? VIVA, VTAC, and asystole. We'll go over what rhythms have the better success rates in a little bit. So exclusion criteria, significant trauma. Why? Well, when we cannulate these patients through the groin, we put hefty amounts of heparin in. We heparinize them quite a bit, and if they've had a traumatic mechanism of injury, they're just going to bleed out and they're going to die anyways. Any pre-existing neurological disability like Alzheimer's and dementia, severe dementia. And then significant comorbidities such as cancer, pulmonary fibrosis, renal or liver failure. However, if you have a 25-year-old renal patient and they're pretty healthy and they're young, even though they have renal failure, we actually might still put these patients on ECMO. And then exclusion criteria, these, I just kind of want to talk about these really fast, but these are the big ones. Like, basically, if there's significant trauma or they're like really, really sick already and they're not going to do well in ECMO, right? Like, that's the only exclusion criteria that you need to be aware of. However, because we cannulate in the groin, if we cannulate these patients and they have an active infection, the infection's going to go in their blood and they're just going to die of sepsis anyways. So they don't do well on ECMO. And then Tony was kind of talking about lactic acid. This is lactate. This is a lab that we draw. Who's familiar with lactates as far as lab? Not like a woman lactating, but like, I know how you guys are. A lactic acid is are you guys aware of what it is? It's essentially a byproduct of ischemia to the cell and to the tissue. So it's a really good indicator for us to tell how long a patient's been down. What was your lactate, 24? That's a really, really high lactate. So any lactate over 18, we may not cannulate these patients. Again, it's kind of depends on the story and how old the patient is and everything like that. This lab is obtained in a VBG, a venous blood gas. And so that's one of the first things we're drawing, because we will not terminate or decide to, a lot of the times, or decide to cannulate and put them on circuit if we have that, if we don't have that number back. Another thing we want to be aware of is ETCO2. So if this patient's intubated, what do you guys do for airway? I know you have RSA because you guys are badasses, but like LMAs, is it kind of to your discretion? Do you always intubate?
No, it's discretionary.
It's discretionary. Okay, so if you, let's say you intubate this patient, right, and their ETCO2 is less than 10, and you tell us that in a report, that patient's not getting great ventilations, and so the oxygen is going to be poor, and therefore they're probably not going to have a great neurological outcome. So that may be a reason why we terminate. We want to make this process very, we want to take the weight of the decision making off of your guys' shoulders. And things get cannulated that shouldn't be, and things don't get cannulated that should be. I think it's, we're trying to make it more of a fluid process, but this is fairly new to medicine, right? Well, like within the last 20 years. Actually, Tony had his cardiac arrest in 2013. There was not an ED ECMO program until 2015, so he got really lucky. They actually took him to the OR, and he had a friend who was a really smart human and advocated for him to get put on ECMO. So I actually, I'm also a charge nurse in our ER as well, and sometimes a real nurse, and we were getting a transfer from Park City Hospital, and this patient was a AAA. He was 42 years old, was dissecting. The CT showed that he was dissecting, and they were like, get this guy out of here. He needs to go to the U where there's cardiothoracic surgeons. Got him to us, GCS 15, vitals were somewhat stable. He was on an ECMO wall drip, and he was fine. He signed his own paperwork to go to the OR, his consent form, and he coded right in front of his wife in my trauma bay. They cannulated him. They put him on ECMO. He obviously didn't survive, but like that would not be typically something that we would cannulate. So let's say, perchance, that you were to bring in a cardiac arrest, which you would never do by ground because you're way too far from us. But we don't want you guys to be discouraged if something is coming to us, because there are a lot of things making this decision. The surgeons are thinking about stuff like neurological outcomes, quality of life, story. There are just lots of different, these labs that you may not be aware of. So this criteria, all of our charge nurses have it. So when I'm taking calls on our biocom and the radio, it's right in front of me on my desk. And then if I ever have questions about it, which I do, because it's not all black and white, right? We all operate in gray. We're all in emergency medicine. And so I will often reach over to my docs and be like, hey, what do you think about this? Should we activate? But ultimately, like, if you guys think that you guys have a good candidate for an ECMO eval, call if you have questions. Be like, hey, like, what do you think about this? This is a story. This is the time, and that kind of thing. And then I'm hoping to actually leave you guys with criteria just so you're aware of it. Hopefully like a digital copy and then a hard copy that you guys can look at, just so you can have reference to it. Another thing I forgot to mention with our criteria, I think this year because of our packed snowfalls, there's cold, swift water, right? Some of the best patients that we ever have are actually cold water drownings. It's actually where ECMO was first started, especially in pediatric patients. So because you guys are a little farther away from the University of Utah, I mean, I think that like that could be potentially something that happens this year just because of the nature of our snowfall, and they happen to do really well. All right, one of the things that is part of our criteria is, and I talk about it on this slide. So from the time of cardiac arrest to the time of cannulation, we want that to be within 60 minutes, okay? And so timing is of the essence with these patients for them to have this opportunity. So there's a mindset, right? There's a stay and play mindset. Typically, EMS doesn't bring dead patients to hospitals, right? You stay, you work that patient unless something changes, if you get a ROSC or, or whatever. ECMO is kind of changing the way we do things. So it's the stay and play versus load and go. So I'm going to ask you guys some questions. What is your ETA typically to the U? 35 minutes by ground? 40? 35? Okay. And then how much time are you staying on scene to code these patients? What's your typical code time? I know it kind of it's dependent on rhythm and how the patient is doing.
15 to 20 minutes.
15 to 20 minutes. Is this patient a candidate for ECMO? That's kind of one of the things that I want you to start thinking about. And then you guys have auto pulses, right? From my understanding. Auto pulses are phenomenal. They're so great. And Lucas devices, because it allows us to code these patients, I think, a little bit better, especially if they're a little bit larger. We've actually we've kind of changed the way that we do the transfer of care in our emergency department. But Lucas's are very, very helpful. We have one in my emergency department as well. And then what is your response time typically to from the call that you get dispatched to the time of scene of arrival?
5 minutes or less is kind of what we shoot for.
Okay. That's actually really good. So obviously all these questions.
That's what we shoot for.
Okay. It's still pretty good.
It's pretty good.
Yeah.
It's pretty good.
When I did this training in Park City, they were like up to 20 minutes. So I'm thinking that's pretty awesome. But these questions all surround timing, right? Because timing is one of the most important things to consider. And then the biggest challenges include downtime to arrival of hospital, quick decision making to stay or whether to transport, and then knowing if it was actually a witnessed arrest. So this one's particularly important. There was a firefighter who went to cardiac arrest in Salt Lake City. No comorbidities. He was 27, 29. He was under 30. Super young, healthy guy. I was actually a nurse on the floor that day. I was his code nurse. And in the ER, all the nurses run codes. And I was like, man, we got to get this guy, we need to get him cannulated because he's super young. They're like, well, it was a PEA arrest. So his initial rhythm was PEA. On top of that, the way they decided not to cannulate this gentleman is because they were told that it was not a witness arrest. In Salt Lake City, 2 captains respond to every code. So the girlfriend was screaming her head off, and so one of the captains took her away from scene, and then the other captain stayed and helped run the code. Well, the 2 captains on scene did not communicate efficiently because when the captain was with the girlfriend, he found out that she was in bed with him when he went to cardiac arrest, heard some gurgling, turned over, he was blue, started CPR, right? And then the other captain that actually went up with the patient who gave us a report in the trauma bay said, you know, it was not witnessed. She came in 10 minutes later and he was found down. So this patient was not cannulated. That is a patient who could have potentially done really, really well. It was witnessed, he had CPR right away, and he had no comorbidities and he was young. So the story behind what around the cardiac arrest and what happened is so important to if these patients get on pump or not. Some things some people have done to implement this quick decision making, because we all know, we've all worked cardiac arrest and been on scene, that time gets eaten up pretty quickly, right? Time is, it could be 20 minutes and you think it's 3 minutes or vice versa, right? So for instance, Salt Lake City has implemented a 10-minute ECMO check. Obviously, they're a lot closer to us. So they're getting over the radio and being like, hey, this is your 10-minute ECMO check. And it helps prompt the medics and EMTs to be like, oh, yeah, we've been on scene for a little bit. So the biggest challenges we see are timing and communication. Timing because the U is in the perfect central spot of location with no construction at all. And communication, just because patients literally don't get put on pump for communication. And there's a lot of things that have to go right on these patients as well. The next thing I'm about to show you, so this is a hot load protocol. This is actually what Park City does. So Case, do you want to kind of talk about the protocol? You know it a little bit more than I do.
The hot load?
Yeah.
So we've done a lot of training with Park City Fire Department, streamlining our timing basically. For them it's pretty close on them just grabbing a patient and getting to the hospital versus meeting with us and getting to the hospital. So what we've done with them is they actually have like rendezvous points that they want us to go to. So we'll go to a rendezvous point and have the helicopter ready, like blades are spinning, clamshell doors are open, like the helicopter's ready to go. As soon as they pull up, we go over there. We've worked with them on like the equipment, what we're gonna do as far as transferring equipment, getting them onto ours. But basically their ambulance pulls up right next to the helicopter. We grab the patient, put him in the helicopter and go. And the scene times are less than 5 minutes. So we've really streamlined that for us. And with you guys, like we already do like helipad rendezvous, right? So that would just be one of those things, I'm assuming where Karie's heading is, that it would be like, hey, we're bringing you guys a patient in cardiac arrest for ECMO, and we would just go out to the helicopter, get everything ready, probably have the helicopter going, and then as soon as you guys just bring the ambulance over, we'll just grab them, we can work through those details on equipment, transitions and stuff like that, and just get them in the helicopter and go and streamline the process. But it's really, we've had that program with Park City Fire for like 2 years now. Everybody on our side is trained, everybody on their side is trained because we do these trainings regularly, and it's crazy fast. We compare, the scene times with the Park City base and Park City Fire to other places, and like I said, it's like less than 5 minutes from when we get to the patient to when we're in the air, so it's super quick.
Do you guys, have you guys noticed in your communities so in our emergency department, since January, the amount of 20, 30, and 40-year-olds going into cardiac arrest, it's crazy. I've never seen it in my 8 years in my career. And these are the patients that do, like, the younger they are, the better they do, right? And I want your guys' community to have the same opportunities, not just because of how far you guys are away. Again, this is maybe something to consider. I don't know if it would be possible. I don't know your protocols. I don't know your demographics as far as like getting to the U and things like that. But just kind of a potential for you guys' communities. What questions do you guys have?
Well, my first one is so you will fly patients in code now, because it used to be kind of like, they're code and we're not gonna take them.
Still, our thing is we don't fly patients in cardiac arrest, with the exception of these ECMO cases.
Okay.
So we would keep them. We've done a lot of work with the Lucas device and making sure that fits in the helicopters, both styles that we have. I assume the auto pulse is going to be the same. We can already fly the auto pulse, that's not an issue. But ensuring, adequate spacing or whatever, which I really doubt would be an issue. But, so we would just keep them on the auto pulse, throw them in there, throw them in the helicopter and go. And then we'll just hang out at the hospital until they're taken off of the auto pulse, and then fly back and make sure we call you guys to make sure you get your equipment back right. So yeah, that's the only exception to flying people in cardiac arrest, is if they're a relatively young, relatively healthy person in a witnessed arrest, flying to the U to get ECMO. So, yeah.
Something that's still coming down our pike is that we're gonna do some training with AirMed and see our feasibility and practice doing the auto pulse and transferring a cardiac arrest patient.
Does anyone have any other questions? Okay, I'm gonna have Dr. Tona come up and have him give his presentation.
Hey all.
You can.
As mentioned, I'm Joe Tone. I'm an emergency physician and an ICU doc up at the university, and I run their program. And I'm not going to go through all these slides, but we're going to go through some. But I wanted to just talk with you a little bit because I think it's helpful if you just understand conceptually who we're trying to put on and why, because there are so many factors that go into the decision making for who we're going to put on and why and when and whatnot, that like I couldn't even make a list if I tried, because it's constant. There's so many things and they're constantly dynamically changing. that there's, it's not fixed and simple, it's conceptual, and so it's a very individualized decision in every case. And it's also gonna be highly dependent upon which of the physicians come down. As was mentioned, when we put people on for ECMO, not only are we trying to get them to have adequate blood flow conceptually, but we think that there's something that we can fix. So if they had a cardiac arrest and we know we can't fix whatever caused that cardiac arrest, we're not gonna put them on ECMO. So the ECMO is just a bridge to give us some time to fix whatever put them in arrest. And we're only doing that to people who we think also have a brain that still works. If we think that, they've been down for so long their brain doesn't work, then we're also not gonna do it. So all these things are coming together. And so I wanna talk to you about some of this stuff because I think it'll help you kind of understand what we're doing. And as I said, when we do this, the ICU doc comes down, the cardiothoracic surgeon comes down, and the interventional cardiologist come down, because almost all of these cases are acute STEMIs, and they go to the cath lab, because just like a STEMI has a door to balloon time and we're trying to get them to the cath lab really quickly, if we put them on ECMO and we forget the fact that they're a STEMI, then we haven't helped them at all. And so we have to put them on ECMO and still get them to the cath lab within that door to balloon time. And so if any of those one pieces isn't perfectly aligned, we might not put the patient on, or it might not happen. And so, and I have about 8 colleagues in the ICU who work with me, and I'm the medical director of the ICU, so I tell them kind of how to practice in this way, and they don't even listen to me all the time. And so don't be surprised. I want, what Karie said, when you come in, if you're thinking this patient's going to go on ECMO, and all of a sudden they don't, or you didn't think there was a chance they were going to go on ECMO, and then they come in and they say we're going to put them on ECMO. Don't take it personally, because there are so many factors that are at play that it's never up to one thing, and I don't even have the power to say no matter what we're doing it or we're not doing it. It's very dynamic. Okay, so the thing that to remember is that one, this is probably important to know. So 40 years ago, this is what ECMO looked like. It was very different than it looks nowadays. And this was the first trial that was done in ECMO. It was adult, and 50% survival is if you stay up here, and 0% survival is you stay down here, and this is days. So over time, like, everybody died, and and that was just because medical care was really different back then. And so what you notice is the group that got ECMO, the group that didn't get ECMO, both died. If you talk to anybody who's over the age of 50, who's a physician, they're going to tell you that ECMO doesn't work. And what you can see here is really just medical care didn't work, right? It didn't matter, if you got ECMO or not. It was just that the care was really bad for these patients. But know that people aren't always going to, especially if they're older, are not always going to be very excited about the idea of ECMO. So ECPR is just chest compressions, and then we're trying to add ECMO in order, and we can do it, wherever. And the whole idea is that, as you know, is that chest compressions are really bad. It's the best thing we have right now for cardiac arrest, but 9 out of 10 people who have a cardiac arrest die, right? There's a 10% survival. So the odds are they're gonna die. And part of the reason why that is, conceptually, chest compressions just aren't very effective. In a very young, healthy person, especially in a kid, they're much more effective because the ribs don't break, and so they're constantly recoiling and helping, move blood. But in somebody whose ribs start to break, you lose that recoil and you can't effectively pump blood. And so we think that ECMO is better because it provides full blood support. We can leave people on ECMO for weeks, and they're totally fine with no cardiac function. It can provide full heart and lung support. And so if we can get them on ECMO, we can stop the chest compressions. And the chest compressions, lose efficacy over time, whereas if we just leave them on ECMO, they're fine. And so the whole idea is this: if we're gonna do this, we want to get them on ECMO quickly. And the reason why I care about this is a photo of Woodstock the first year, and it's estimated that there are about 500,000 people in this photo. And this is the number of people in the US each year that have a cardiac arrest. It's a lot of people, and 9 out of 10 of these people are going to die, right? And so this is a problem that really bothers me, and we should be able to do better, and you guys dedicate your lives and your careers to doing better, and so that's why I'm here talking with you, because I think that the ECPR for select patients is better. These are the curves that you know intuitively from what you see, but you may not have seen on paper. So once again, these are what are called survival curves. So 40% survival is the top line, 0% survival is down here, and this is CPR duration. So this is the probability of survival, and red is neurologically intact survival, brain's intact, over time. And go to 20 minutes here. So 20 minutes of cardiac arrest is not that long, right? Like we code people for 20 minutes all the time. And at 20 minutes, you have a 5% chance of survival and about a 3% chance of neurologically intact survival. Now, what you guys all know is that if you have somebody who has a cardiac arrest in front of you, you put the pads on them, they're in VFib, you shock them, and they wake up, they pop out of here, right? So they don't contribute data past a few minutes. But the people who are still in arrest, meaning you're providing medical care, you're shocking them, they don't come out, you're shocking them, they come out, they're not shockable, you're still doing compressions. Over time, this is a self-selecting group. But if you are still doing compressions on somebody by 20 minutes, you know, they're basically dead. And so let's talk about a little bit of the trials here. There's 3 of them, and I think if you understand the difference between these trials, you understand the benefit here. So this was the first trial that was done for ECPR. So one group got ECPR, one group didn't. It was only patients who had VF arrest. So no other rhythm, just VF. And the reason is that those patients, for the most part, probably had STEMIs, and we'll talk a little bit about this. But VF arrest, adult in Minnesota. Blue group got ECPR, 50% survival, right? So they did it in 2 people, one of them lived, 50% survival. The red group did not get ECMO, everybody died, right? So after 30 patients were enrolled in this trial, the safety board said, you're not doing any more patients. It's not ethical to not give people ECMO. In this situation, it's not ethical to not offer ECMO, because at the ECMO group, 1 out of 2 was living, and in the non-ECMO group, everybody died. So, you know, probably pretty good in that situation. Second trial was a little bit different. This was in Prague, in this trial, they included all types of rhythms. So shockable and non-shockable, PA and asystole. Same thing, out of hospital arrest. A lot of them were witnessed, so they saw it. People started chest compressions. The group that got ECMO had about a 31% survival, so a little bit less than the other group. The other group was actually about 40, 45. And then the standard group was about 10% less, at about 20% survival. And so, you know, the difference here is likely related to the fact that you included these non-shockable rhythms. I'll show you data in a minute that patients who have shockable rhythms have the best probability of survival. You have, you know, if you have a non-shockable rhythm, you still can survive, but it's less likely. Something like asystole, even less likely. There's a graded response to what type of rhythm you initially have. And then the last trial that was published, the first 2 trials were a group of doctors. There were very few of them who were actually doing ECPR. There were only probably 4 at each site or 5 at each site. They had done hundreds of these ECPR cases, so they were very practiced. And you saw those results. In this trial, it was a bunch of different doctors from a whole bunch of different specialties who were doing it at a bunch of different hospitals. And they didn't do very many of them. Some of them had only had a couple of ECPR cases in their whole career. And then they're doing this. And there was no difference in survival between these 2 groups. And so the point being is that, you know, if you have a really tight, focused program with only a few people doing it, you're doing a lot of these cases, you're going to do really well. And if you're including a whole bunch of people with a bunch of different rhythms and a bunch of everybody, you're much less likely to have good outcomes. Also, you know, in this one, PCI is going to the cath lab, so they only took about half the patients to the cath lab. Once again, we said all these patients probably have STEMIs, so if you think you have a patient who has a STEMI and you put them on ECMO and you don't treat their STEMI, guess what? They might die, you know? And so that's what you see, that, you know, if you don't do all these other things, these patients don't live. So the last two concepts I want to leave with you is this is survival according to initial rhythm. So I've tried to say a couple of times that, you know, people who have shockable initial rhythms have the best survival. And there's 2 reasons for that, and we're going to break it down. So you can see here, this is survival of all patients, VF patients up to 60%, PEA less than that, asystole even less than that, right? And the reason why that is because patients who have VFib initially are very likely to have had a heart attack. If you are living your life, you have a big STEMI, there's a good chance, if it's so severe that it causes cardiac arrest, that initial rhythm is going to be fib. And so when you see a patient who is in fib, the first thing I'm thinking is this is a heart attack. Like just about everybody. Fib, heart attack. And so those are the patients I really want to try and resuscitate because I can do something about that heart attack. If I see a patient in front of me whose first rhythm is PEA, it could still be an MI, but it might not be. It might be a big PE, I can treat that, but it might be something else. If I see a patient whose initial rhythm is asystole, I'm immediately disappointed, right? Because the things that cause you to go into asystole, like from normal sinus to asystole, not good, right? And often that first asystole conceptually is probably somebody who actually has not been circulating blood and oxygen very well. You know, so you think about it, somebody uses a bunch of drugs and sits in the corner and kind of occludes their airway for like a half hour, you know, and they're only moving a little bit of air and their CO2's going up and their oxygen level's going down. You know, they're in a period where they're not doing real well, and then all of a sudden they're probably going to end up in something like PEA or asystole. They're not going to go into fib at the end of that period of time. And so this is important because when you guys get called, you don't always know it was somebody, you know, running a race and fell over. You hear this story of, oh, I saw him 15 minutes ago. Well, was it 15 minutes ago and they had a cardiac arrest 15 minutes ago and nothing's happened for 15? Was it 15 minutes ago and they were fine for 14 and then had a cardiac arrest right when their wife walked in? These are the things that are always unknown to us, but that first rhythm tells me a lot. If it's V-fib, I'm thinking it's something like a heart attack that I could fix. If it's PEA, probably also. Asystole, a lot less likely to be something that I can fix. The second reason why the rhythm is important is this. So this is a complicated graph, but I'll walk you through it. So once again, survival curves, 100% up at the top, 0% at the bottom. This is time from collapse to first CPR. So this was a whole bunch of cardiac arrests, and they recorded the amount of time it took from the moment the person went down to when EMS first got there. And then when EMS first got there, they wrote down the rhythm that they saw. And then they graphed it out here. And so if it only took EMS, 1 minute to get there, the blue here is V-fib. And then the red is asystole. So about half of them were in asystole, if it took 1 minute. And about 20% were in fib. If it took them 15 minutes to get there, 70% were in asystole at that point, and only a few people were in fib still. And why this, so what you see is that fib goes down and asystole goes up over time. And why that is that if you have a heart that's in fib and you don't do anything, it will eventually degenerate. And you all know this because you start with these patients in fib and you're working them, and maybe you're not getting good compressions, maybe you are getting good compressions, but over time, it's very unlikely that that heart is going to stay in fib, right? It's going to go into something else. So, the takeaway points from that are, it's okay if it goes into something else. You're working them, I'll still consider that first rhythm. I'm not worried about what the rhythm the person's in by the time they get to me. I want to know that first rhythm. The second thing, though, is that if you come upon a patient and they're in fib, it suggests that probably they haven't been in cardiac arrest all that long. Because even if they had an initial fib rhythm and they're still in fib, it's probably not been that long. Whereas if they are untreated fib, it's going to go to something else over time. So that initial rhythm is going to tell you a little bit something about how long they've been in cardiac arrest before somebody showed up and started compressions. The other Pearl takeaway is that when you have that patient who has recurrent fib at like 20 minutes of you're shocking them and shocking them and shocking them and shocking them, I really want to put that person on ECMO, right? Because that heart is doing really well, right? It's getting enough oxygen to stay in fib. You're doing good compressions and you're treating that fib. Now we just got to kind of get something to fix that. And oftentimes the fix that is cath. But we got to get them on ECMO first to stabilize them out because we don't want to keep having to do compressions. So it's especially those patients who are in persistent fib that I really want to put on. I don't want to show this graph, it's too confusing. That's kind of it. So, those are the takeaways, is that, patients who are in fib do much better. It also tells you that you're probably not been in cardiac arrest that long, and you probably have had something that you can fix, like a big STEMI. If you're in PEA, less so. If you're in asystole, less so. Don't worry too much about these things. I don't want you to make decisions based on this stuff, but I want you to understand kind of the concept of who we're putting on and why. And if there's one takeaway, is that if you're thinking the patient is potentially an ECMO candidate, get them to us as fast as you can, right? Because once we decide we want to go on ECMO, we want to do it as quickly as we can. I didn't show you, I'll tell you a little bit something about some of those previous trials. So remember this graph here, which is the survival over time. So in both the two trials of ECPR where the patients had really good outcomes, 30 and 40%, they were going on ECMO at 60 minutes. So that's patients who by 60 minutes here, the graph ends at 60. So at 60 minutes, these patients without ECMO had a 0% chance of survival. But when they went in the ECPR trial and went on ECMO, about half of them lived, or 30% of them lived in those two trials. And so that's true, is that even if you get out this far, if we put them on ECMO, we can potentially bump up that survival from here. This is without ECMO. If we put them on ECMO, we can bump up their survival by 10, 20, 30, 40%. The last trial where there was no difference in outcome between the two groups that got ECMO and didn't get ECMO, it took them 75 minutes to get the patients on ECMO. And so we think that probably if you're going to put somebody on ECMO, you should do it within an hour. And in fact, talking with the people from Minnesota who did that first trial, their data is that anybody who they put on ECMO within 30 minutes who has VFib, initial VFib, 30 minutes, ECMO, 100% survival, every single patient. So it's rare that we get a patient within 30 minutes of their initial arrest, but if we can get it to us within 40 minutes, within 45 minutes, there's a pretty good chance that we'll be able to get them on, and if all goes well, they'll do pretty good, right? So if you're gonna bring us, if you're thinking a patient's good for ECMO, as soon as you can get us the patient, the better.
Do you get many inter-facility transports to come down for ECMO?
Only ones with a pulse. So we get a lot of patients who are referred needing to go on ECMO, but they're not in cardiac arrest. Putting somebody on ECMO who has a pulse is pretty easy most of the time. It's not that easy if you lose a pulse, because finding the vessels, the vessels immediately collapse down, and when you start doing compressions, they both become pulsatile, the artery and the vein. So I'm like, oh, which one's which?
Right.
So I just got to go on anatomy. Oh, the artery is supposed to be to the side.
The thinner the patient is too,
Yeah.
it's super easy to get them on.
Yeah.
But the bigger the patient, it's gonna take some time.
Yeah. We try and put femoral access in everybody who gets brought in for cardiac arrest, and skinny people or almost-sized people, I can generally get vascular access in about 5 minutes. People who are obese, sometimes I don't get it.
Yeah, understand. I wonder how hard it's going to be, and I know we're talking about this, becoming more of a thing, but to get local physicians on board with the idea of us going, hey, this is an ECMO count, we'd actually like to fly them to the U rather than bring them into your ER. I don't know, I just wonder how they're gonna buy off on that. I'm on board 100%, especially with the numbers, but it's a big shift, but it's a big change in a thought process to sometimes get them to come, get on board with it.
Do you guys transport patients in cardiac arrest to the local hospitals very often?
Not, we used to almost transport everybody.
Right,
And of
yeah.
course, COVID was a big change in our thought process on, which we probably should have been thinking like that before anyway. Usually if we do 3 rounds, full CPR with all the meds and everything else, and there's no change or it's not getting better, then we'll usually make a phone call and call it in the field. But once in a while, like I said, young people,
Yeah.
that we feel like
Yeah.
they have a chance of survival, depend, you know, like, again, it's that fluidity of every call is just a little bit different, but we don't transport a whole lot that we don't get some sort of positive change.
Right.
And if they're in a shockable rhythm, then yeah, you know, they stay in one, we'll transport them, but once we go, you know, we get PA, systole the entire time kind of thing, then very rarely do we transport those patients.
I guess I kind of view it like our trauma patients, right? Like I know at Holy Cross Davis now, right? Like we had, you know, some misinformation. It was like, okay, well, can we take the patient if, you know, you guys bring us a patient, but then it's not, you know, like
Oh,
there
yeah.
was that whole issue, right?
Oh, yeah.
And that got clarified. And I think it's just kind of the advancement of medical care, right? Like a trauma patient needs to go to a trauma center, and that's the appropriate facility for them. And so I think going down the line, this will get more and more clear. Like, okay, this is an ECMO candidate. They need to go to somewhere that can place ECMO rather than just a local
Well, an
ER.
arrest to catheterization within 60 minutes is actually a pretty feasible number if you guys are sitting on the helipad.
Yes.
And that's why I look at that and go, this is actually a viable option for us to get patients down there that are ECMO candidates. Like I said, hopefully we can get the education to these local physicians that, just like you said, in fact, they don't usually want us bringing a trauma one through their doors anyway. They're like, no, take them take them anywhere but me kind of thing. And you know, if we can get that mentality of this is an ECMO candidate, we're coming to your hospital, but we're going straight to the helipad.
Yeah.
So those physicians that you're talking about are coming next month
Oh, good.
to the training.
Yeah,
So
well, you
they'll,
have an important job to do.
so they'll get the
You have a very important job to do.
they'll get the exact same training that we're providing.
Good.
I think that I think it's a culture shift for you guys, and not just for you guys, right? It's a culture shift for emergency medicine, for the whole system, right? And so, and again, why should someone, just because they live in Salt Lake City, have this a viable option just because you know someone lives in Layton? Like, we want you guys to be able to just have this tool in your toolbox to be like, hey, because I think you guys all have a pretty good intuition, and you guys are like the first person to be advocating for your communities and for your patients. And so to have this option now obviously this is not going to be an option for every cardiac arrest, nor should it be.
Right.
But given the chance that you're like, hey, I actually think that this person has a chance, like the Flutter VFib patient, or you know, especially if they're really young, because the perfect cardiac arrest patient for ECMO is a 20-year-old male who gets on ECMO within, or female, okay, yes, this is true. I'm sorry, all the cardiac arrests that I've had, all the cardiac arrests I've had are male in their 20s. But my point being is, like, the younger they are, the healthier they are, and you get them within ECMO within a certain time frame, they're going to live. They just will.
Right.
And we want you guys to have that option here in your communities for your people.
Yeah, I love it, yeah, awesome.
So,
Well, good, get them sold.
oh. The data
Yeah,
says it.
it's hard, you can't, it's science, right?
Yeah, this is true. This is true. Do you guys have any other questions?
How big is the equipment?
Oh, it's tiny.
Pump and-
It's little.
It's weirdly
Is it
small.
one piece or?
No, it's so you
The
have
pump
the
and the
tubes,
oxygen.
right? The two tubes,
Yeah.
and then the pump is.
Yeah, the actual pump is about this big. The motor that drives it is about this big. The oxygenator is about this big. And then the device that actually runs it, that actually runs it is probably about this big. So do you need to go outside?
So yeah, when these patients get on circuit and then on pump, so we'll cannulate a lot of these patients just so we have access. Like Dr. Tona actually just a few weeks ago cannulated a 42-year-old arrest who actually got ROSC in our bay, and he had him cannulated within minutes because the guy was so skinny and so healthy, and then he got cannulated but didn't get put on the circuit. And it's super crazy because actually couple weeks ago, we also had a 42-year-old male who went down in his cubicle, they heard him collapse. He got put on circuit. And even though he was on circuit, like, he was in full-on VFib, but he was having purposeful movement because, like, you're getting oxygenation to the brain without a heartbeat.
That's crazy.
Yeah, but it's small. It's really small.
That's just,
Have you guys heard of Reboa? Reboa is another thing that we're doing. We're actually, would you say it's a little more, is it newer than ECMO, Reboa?
For sure.
Reboa is essentially where they'll throw a balloon, right? They throw it in your arteriole,
Yeah.
and then they tamponade your aortic artery, and they'll do it most of the time above your kidneys, right? So it shunts blood from, like your kidneys aren't getting perfused or anything like that, but it shunts blood to your brain and your heart and your vital organs. And is it 60% Ross with a Reboa?
I don't know.
I thought Yumko said it. Anyways, so they'll use it in conjunction with ECMO. I actually think that it's possible. AirMed's flying our surgeons to other hospitals. Like we just flew a surgeon out to West Valley, or did we not fly? No, we flew to place a Reboa on a postpartum hemorrhage. But it could be really huge for like pre-hospital and maybe someday a paramedic procedure that's done. So a lot of like cool technology, cool things that are helping in the cardiac arrest. Okay.
What kind of, you talk about with VA, you actually are getting pressure support on top of the oxygenation. What kind of pressures do you usually see when you've got something on that?
It's hard to know in isolation because they're often got a bunch of epi, but like normal blood pressure.
Okay,
Normal blood pressure.
very cool.
I'm gonna, isn't your email on the end of this? Dr. Tona's email's on the end of this. If you think of any questions, or even me, I'm happy
The bottom of
to.
that slide too, looks like.
Is it? Oh yeah, it is. This is Dr. Tona's email. And I have some cards that I can give you too for